As I'm able to see my patient, I'm gathering my general impression: male, female. How old do they look? About how much does my patient weigh? I'm looking at my patient's appearance. Do they have any facial expressions, faces of pain or sickness? Looking to see if my patient makes any eye contact or is looking around or not at all. Looking at what my patient is wearing. Are they in too much pain or sickness to even care? Are they talking? Does it sound appropriate? Do they smell of any odors like alcohol, fruity, or do they have bad body odor for not caring? Next, I'm looking at my patient's work of breathing. Is my patient able to speak in full sentences or only able to say a few words at a time before needing to take a breath? Does my patient have any abnormal breath sounds? Deep, shallow, tachy, or is my patient abnormally postured like a tripod position? Is my patient retracting to open up their airway? Do I see any nasal flaring? Lastly, I'm looking at their skin tone for circulation. Are they red, which could be a sign of fever, sunburn, or allergic reaction? Or are they white, which means shock or anemic? Or maybe they are blue, being cyanotic. When I'm at my patient's side, I'm determining my patient's responsiveness and level of consciousness. Are they alert, acknowledging I'm there? If so, are they oriented? I'll ask them if they know their name, do they know where they are, do they know what day, month, year, or season it is, and do they know the president? But if they're not alert, then do they have any response to verbal stimuli? So I would speak to them to see if they look at me, move, or make a sound. If nothing, I'll try pain stimuli by using sternum rubs, pressure points, or nail bed pressure and look for a response with sound or movement. But if none of that works, then my patient's unresponsive. Moving on, I'm looking for any threats to life. Is the airway blocked? Is my patient's breathing disrupted? Or is there serious hemorrhaging? If any life threats are present, I'm stopping my assessment to treat the life threats and determine if to need a transport. If there are no life threats, I'm determining the chief complaint either by asking the patient or what's wrong or whoever called 911. Next, I'm assessing the patient's airway to check if it's open, secured, is there any audible sounds of obstruction, or are they able to speak in full sentences. I'm also assessing their breathing. Is it too fast, too slow, too deep, or shallow? Are there any audible breathing sounds? I'm looking to make sure there is equal rise and fall in the chest. Does my patient have proper ventilation? If I find anything abnormal, I'll place my patient on proper oxygen therapy. Next, I'm assessing my patient's circulation, making sure there's no major bleeding. Then I'll place my wrist on the patient's forehead to check for a temperature and texture of their skin, and looking to see what color my patient's skin is. I'll move on to palpating my patient's radial pulses, making sure they are not tachy or bradycardiac, weak or irregular. Make sure both radials are pulsing the same, and if I don't feel any radial pulse, I'll be checking the carotid pulse. Next, I'm assessing the patient's disability by checking the PERLA and GCS. First, I'll take a light and check each pupil by moving the light on one pupil, then away and back on the same pupil, and vice versa for the other side. I'm looking for equal, round, reactive pupils and looking to see if their pupils are constricted, dilated, or normal size. Then I'll be calculating their GCS, eyes, verbal, and motor response. For eyes, it is 4, patient opens her eyes spontaneously. 3, eyes open to response to my speech. 2, eyes open to pain. 1, patient doesn't open their eyes. Then verbal, 5, patients oriented times 4. 4, the patient's confused or disoriented when talking. 3, the patient has random speech and no conversational skills. 2, patient makes sounds but no words. And 1, no verbal response. And finally, motor. 6, the patient obeys the commands or simple tasks I ask. 5, localizes response to pain. 4, withdraws from pain by pulling away. 3, flexes the pain, the corticate posture. 2, extends the pain to cerebrate posture. And 1, no response. Now I have a GCS, and I'm moving on to expose their chest. That way I can examine their lung and heart sounds and place a 12 lead on them if I need to. Lastly, I'm making that transport decision. Am I low to go or am I stay and play? And giving that patient a priority level. Critical, unstable, potentially unstable, or my patient is stable.